Thank you so much. Just wanted to give a disclaimer that this is supposed to be Dr. Mirbat Al-Asnaj's talk, so asked to fill in last minute, so bear with me with some of the slides that I prepared last minute. All right, so with the next 15 minutes, we'll talk more about the patient selection, but also the types of clips that we're going to be using for each patient. So when we talk about suitability for a transcatheter edge-to-edge, you have to think of it in two ways, other than patient, obviously, as a whole condition. But one, we're looking at the mitral valve itself and the mitral valve apparatus, so anatomically, and also the LV itself, whether it's dilated or not. This is the criteria that was first established by Everest. And as you all know, Everest was looked into for primary MR. And if you look at the optimal, the first column, this was actually, it's probably less than 50% of the patients that we see nowadays. One is that you're looking at central pathology, A2 to P2. You're looking at no calcification in the cord or the mitral valve apparatus. You're looking at mitral valve area greater than 4. And a posterior leaflet length that's greater than 10. You're looking at a great mobility, and which, if it's a secondary MR, you're looking at a tenting less than 100 millimeter, and a primary MR that's flail width less than 15 millimeter, and a flail gap less than 10 millimeter. So what has changed from now till now is that the devices have they're coming in different shapes. They can accommodate smaller valves. They can accommodate shorter lengths. So we've moved from the optimal to more expanded, suitable and expanded. Now, if you look at the bottom of this chart, that you can see that optimal could be done in a lot of centers, but as we get to a more complex anatomy, you need to have really high experience, high volume center to be able to navigate those complex pathology. So a few things to point out here is that we've moved away from the A2, P2 to expand it to A1, P1, P3, A3, P3, which are more medial and lateral. But those have to be, you have to make sure that you have enough actually room to open your clip and grasp. But it's not still approved for cleft or perforation. As far as no calcification, we're accepted some calcification, but it has to be not in the way for you to be able to grasp the clip itself or the cord. As far as mitral valve area, this has been kind of talked about in the previous talk, that the optimal is more than 4. But up to 3 and above, we can actually think about implanting a transcatheter edge-to-edge repair. When it comes to gradient, it's a bit of a kind of complex assessment of the gradient, because some of the gradient might be related to the MR itself. We'll talk about that in the next few slides. For leaflet length, it used to be 10 millimeter just because of the devices, but now we have shorter devices, so we accept it down to 6 millimeter and above. Moving on to the next slide is we've talked about the anatomical consideration, but more importantly, it's also important for secondary MR to look at the LV, which also was touched upon in the previous presentation. So this is the latest heart failure guidelines that was published last month. Kind of goes along with the valvular guidelines that you have an indication to do a transcatheter edge-to-edge mitral valve repair, and it was given 2A. One thing to highlight, that it's actually given as a primary intervention for those who have an EF between 20 and 50% and not a significantly dilated LV with an LV and systolic dimension less than 70. Now, keep in mind that surgery was not actually put in as a primary, so even those who are surgical candidate can still go for transcatheter edge-to-edge just because of the latest recommendations. So this kind of goes along with the disproportionate proportionate MR. So we've seen the differences in outcome in the MITRA FR and the COAPT. And the main differences come from two things. One is the AROA, so it is more severe in the COAPT compared to MITRA FR. And two is the LV and diastolic volume, which was more dilated in the MITRA FR. So what we're trying to say here from this graph is that in the MITRA FR, you have a proportionate MR. You have a dilated LV, and with that dilated LV, you expect a degree of MR. So that proportionate MR is not going to help. It's not going to get a lot better if you actually just do a clip, because it's an issue with an LV itself. In COAPT, it's an issue that the MR is more significant than the dilation of the LV, and that's when an intervention would help. So nowadays, what we typically do is when we look at the severity of MR and in a secondary MR, we get this ratio of EROA divided by LV and diastolic volume, and if you get 0.15 or less, this is proportionate to MR. So we tend to treat them medically. And we've actually screened patients, and we end up not doing it just because knowing that medical therapy is as good as just putting in a device. Whereas greater than 0.15, meaning that the EROA is actually more significant and the LV is less dilated, they actually do better with Microclip. So what are the types of clips? We've got the NT, XT, and then NTW and XTW. So what are the differences? I think majority of people here know, but just briefly is that the NT is shorter arms, XT longer arms, and for each device, NT and XT, we have a regular one, which has a width of 4 millimeter, and we've got the W, which has a wider device, which is 6 millimeter. So would you choose one over the other? You have to look at it overall, a whole anatomical selection based on multiple things. But to simplify it, is if you have the MR is coming mostly from medial or lateral, and you've got a short leaflet length that's still within more than 6 millimeter, then an NT would be your best choice. If you have again, same issue. If you have a shorter leaflet but a wider jet, where you can open your where you have room to put in this 6 millimeter device, then you can go for an NTW. Moving for an XT, you definitely need to have a longer leaflet length. And it helps most of the cases where you have a long redundant leaflet, more than 10 millimeter. And XT is mostly preferred in a central jet, so A2P2 pathology. Moving between XT and XTW, W is going to give you a wider range, so you would it would help if you have a large central jet. So another way of selecting your devices is looking at the leaflet length. So if you have shorter leaflets, then you definitely have to go for an NT as opposed to XT. If you have longer leaflets, then you might go for an XT, given that you have enough room to open it. Broader jet would favor a wide device. A smaller valve would favor an NT, given that the mitral valve area is greater than 3. And larger valves could favor all the others. And if you have commissure location, which we talked about, extreme medial or lateral, then sometimes your only device available for you is going to be an NT. Now, even for those that are outside what we call optimal, or when we reach the other spectrum of more than expanded, they could be attempted, but they have to be attempted in a center of excellence. So it's not a place where you were just starting your devices. This is an unsuitable or an attempt that could most likely would fail in these cases, just because you can see the posterior leaflet, first of all, it's short, it's calcified, so it's going to be really hard to grasp it, plus the fact that you don't have enough length to make sure you have enough grasping. So for these cases, I would not attempt in a place where you only do a few cases a year. So one is Microclip Unsuitable. So we've talked about length, so less than 5 millimeter is not suitable. A mean gradient greater than 5 is what we talk about most of the time, but bear in mind that mean gradient might be affected from the mitral regurgitation itself. So relying on the gradient by itself without the full assessment of mitral valve area, of the calcification, might kind of make some people consider it unsuitable when they are suitable. So we have to kind of review it with everything else. A mitral valve area less than 3.5, and if you have significant calcification that's going to be in the way of you of grasping the leaflets, then definitely it's unsuitable. And then bar low, as well as the clefts for primary MR. So a few kind of pushing the boundaries of TER in the next few slides. So one is there a role for TER in failed surgical ring? So we know from the surgical literature that even if you have great outcomes from the surgical ring, about a third of them will fail in about 10 years. So is there a role for a Microclip? There is, but it's a bit of a challenge because you have to keep in mind, first of all, their mitral valve areas are now smaller. They end up having a shorter posterior leaflet, and sometimes the ring itself would make the visibility a bit of an issue. So unless those challenges have been sorted out, and if the device of the jet is mostly central, then there have been reported cases of doing it safely. The other pushing the boundary kind of case is in hypertrophic cardiomyopathy. There have been reports of the use of it to decrease the systolic anterior motion that will result in a dynamic LVOT obstruction. So this is a very interesting case of a 72-year-old lady who had refractory symptoms. She had SAM with dynamic LVOT obstruction. Her baseline gradient was about, resting was 72 and provoked was about 94. So what they did is they placed a Microclip that actually not only alleviated the MR but also the LVOT, the dynamic LVOT obstruction, and immediately they got no significant gradient at baseline and less than 20 gradient that's provoked. So having said that, what's really interesting in that case, but again it's just a single case, is that their baseline gradient was 8 to start with. And that baseline gradient was not because of mitral valve stenosis. And that baseline gradient actually got a lot better in 2 years. So that's probably resultant of the MR and not stenosis. So in summary, it is important to look at Microclip as a whole. So you need to have a really great team, not just the interventionalist. You need a great imaging specialist. You need an anesthesia team on board. You need surgery team on board. So it's not a one-man show. As far as the thorough evaluation, you have to really know your anatomy, what you're dealing with before the procedure, for both anatomical consideration, primary and secondary. And for secondary, it's very important to look into the proportionate versus disproportionate MR. And when you're planning a procedure, also know where your clips are going to be and what type of clips are you going to be using. After your clip after you enter procedure, when you do the clip, you have to also make sure that you've got sufficient grasp. Your gradient is not extremely high, and you've actually improved your residual MR before releasing. With that, I conclude, and I take any questions.